Welcome to your section on the thyroid gland. The thyroid, located in the neck, as you can see below, produces two hormones. The first one, thyroid hormone, is critical in regulating body metabolism, neurological development, and other functions. Calcitonin, secreted by the parafollicular C cells and involved in calcium homeostasis, is also secreted by the thyroid. Conditions affecting thyroid hormone levels are much more common than those affecting calcitonin. Let's look at the anatomy and development of the thyroid. The thyroid is positioned in the lower anterior neck and shaped like a butterfly, as the picture you saw before. It is made up of two lobes that rest on each side of the trachea. A band of thyroid tissue, called the isthmus, runs anterior to the trachea and bridges those lobes. When you go back and look at the picture before, and I'll go back in a minute, the parathyroid glands are posterior to the thyroid. They look like two little pieces of corn embedded in there. And we'll get to that in the parathyroid chapter in the future. Let me see if I can go back and see. Oh, you can't see it in that picture. But I do have pictures coming up in following chapters on the parathyroid gland, which will show you what those look like. The thyroid hormone is critical to the neurological development of the fetus. And iodine is an essential component of thyroid hormone. Iodine deficiency leads to hypothyroidism, mental retardation, and cretinism. Iodine, the only organ in our body that uses iodine is the thyroid, but it is an essential element. Congenital hypothyroidism occurs in 1 of 4,000 births. So how is this thyroid hormone made? Well, in order to make thyroid hormone, you have to have iodine, as I mentioned before. It's a trace element and a key component of thyroid hormone. It's found in seafood, dairy products, breads, and vitamins. We need an intake of less than 50 micrograms per day, or of more than that per day, otherwise we'll have hypothyroidism. Then we have the follicles, and I'll show you a picture of this in a minute. It's the site of thyroid hormone synthesis. Spheres of thyroid cells surrounding a colloid core, and inside those cells, iodine is oxidized and bound with tyrosine residues on thyroglobulin to form thyroid hormone. So here's the picture that I like. And like you said, I'm a picture person. So you see up on the top left-hand side in the plasma, they've got iodine floating around. This is taken up by the thyroid follicular cell, where it is bound with tyrosine, or in thyroglobulin. It makes monoiodotyrosine and diiodotyrosine. From here, it travels via a lysosome to make what is active in the bloodstream as T3 and T4. Let's learn a little bit about what those are too. So those hormones that I just talked about and we just created in that cell, the first one is triiodothyronine, or T3. The other one is tetraiodothyronine. Typically, we call that thyroxine, or T4. That is the primary secretory product. It contains the majority of the organic iodine in the circulation in the blood. It's also important to know that free T4 and free T3 are the biologically active forms of T4 and T3 in the bloodstream. I have thyroid disease, and when I go into the doctor, I always get a free T3 and a free T4, not a T3 and a T4. When it is released into circulation, only 0.04% of T4 and 0.04% of T3 are unbound by proteins. They're usually bound by one of the three: thyroxine binding globulin, thyroxine binding prealbumin, or albumin. Let's look at the control of thyroid function. This you really need to understand in order to understand the diseases that take place within the thyroid. The first thing that happens, and we'll start at the top, is the hypothalamus releases thyrotropin releasing hormone to the pituitary. This tells the pituitary to release TSH. This in turn tells the thyroid gland to produce T3 and T4, where some is stored in the liver and some goes right out to the serum. Well, the feedback effect comes into play as the hypothalamus and pituitary can pick up when those levels start to drop. When the T4 and T3 starts to drop in the bloodstream, the anterior pituitary and hypothalamus pick that up and start to release more of this hormone to the thyroid to tell it to produce more. Well, TSH becomes a major testing factor. If TSH is increased, It means that the pituitary keeps telling the thyroid to make more, but he's not listening. He's not making more. So he keeps telling him to make more, keeps telling him to make more. Well, he's still not listening. So with somebody with a hypofunctioning thyroid where it's not making thyroid hormone, high levels of TSH because it's trying to tell it to make more, but low levels of thyroid hormone because it's not working. A normal range of TSH is 0.5 to 5.0 milli-international units per liter. So this thyroid hormone we talked about, what does it actually do? Well, it circulates in the bloodstream, and in the cytoplasm, T3 is deiodinated to T3. T4 is deiodinated to T3. T3 leads to proteins that influence metabolism and development. The effects of thyroid hormone include tissue growth, brain maturation, heat production, oxygen consumption, beta-adrenergic receptors, metabolic effect, cholesterol synthesis and breakdown, and heart muscle contraction. Very important player in the blood system. So these are some of the tests that we do to determine how well the thyroid is working. First one, TSH, I just talked about, is the most useful. This one is used to screen for hyper and hypothyroidism and see how well hormone replacement therapy is working. We can do a serum T4 and T3. We could do a thyroglobulin to look for, it's usually a good tumor marker for thyroid cancer patients. And we can test for thyroid autoimmunity. This is where antibodies are directed at the thyroid tissue. A couple other tests that are done sometimes are a thyroid hormone binding ratio. It uses thyroxine binding globulin and T4, T3 to see how well it's binding in the bloodstream. Other tools to see how the thyroid is working. We can do an ultrasound of the thyroid. Sometimes it can detect thyroid nodules of a small size. And if they do find the nodules, sometimes they do a fine needle aspiration. This is often the first step and most accurate tool in evaluating those nodules to see if they're cancerous. A small gauge needle is inserted into the nodule and cells are aspirated out. Let's look at the diseases of the thyroid. First one is hypothyroidism. This one is kind of near and dear to my heart because I actually have this. I have the Hashimoto's disease that we're going to talk about in a minute. With primary hypothyroidism, we see a low T4, T3 level with a high TSH in most cases. One of the most common disorders of the thyroid gland, it actually occurs in 5 to 15% of women over age 65. It can lead to low sodium anemia and having high lipids. It can be divided into primary, secondary, or tertiary disease. And most common cause in developed countries is chronic lymphocytic thyroiditis. Individuals should be tested beginning at age 35 and every 5 years thereafter to see if they do have this. So with me, I have autoantibodies after I had my second child, which have decided to destroy my thyroid. So my TSH was elevated because it was telling my thyroid to release more. Because my thyroid has destruction to it, it can't release as much, so therefore it keeps sending more TSH. So having Hashimoto's is hypothyroidism from an autoimmune cause, and you would need to take Synthroid or synthetic thyroid to be able to reverse that. The next disorder is thyrotoxicosis. With this, we find it can happen from excessive hormone ingestion, leakage of stored thyroid hormone from thyroid follicles, or excessive thyroid gland production of thyroid hormone. The symptoms of this one are anxiety, emotional lability, weakness, tremors, heart palpitations, heat intolerance, sweating or perspiration, and weight loss. An example of this is Graves' disease. Graves' disease is the most common cause of thyrotoxicosis. It's an autoimmune disease in which antibodies are produced that activate the TSH receptor. So your features are a goiter, ophthalmopathy, and dermopathy. If you see this lady on the side, you can kind of see her eyes look like they're kind of bugging out. That is one of the symptoms. 15% of patients usually have a close relative with this condition. The lab usually shows very high T3 and T4 with undetectable or very low TSH. Again, the symptoms are the that's a hard word to say, ophthalmopathy, as you can see in the top right, with the orbital soft tissue swelling, injection of conjunctiva, proptosis, double vision, and corneal disease. The cool thing about this is how they treat it. They give the patient radioactive iodine. So the only organ in the body that uses iodine is the thyroid. If we attach a radioactive tag to it, radioactivity will go straight to that thyroid gland and destroy it from the inside out. Another thing they can do is surgery to remove the thyroid. Another disorder is toxic adenoma or multinodular goiter. This is caused by autonomously functioning thyroid tissue. Neither TSH or TSH receptor stimulating immunoglobulin is required to stimulate thyroid hormone production. This has toxic nodules. It occurs in patients with hyperthyroidism, and you can actually palpate those nodules. The treatment is usually surgery, again, radioactive iodide, or medication. So you can see one of those goiters on this patient below. Another issue we see on occasion is amiodarone-induced thyroid disease. Amiodarone is a cardioactive drug used to treat cardiac arrhythmias. Unfortunately, it blocks the conversion of T4 to T3, and it can lead to hypothyroidism in 8 to 20% of patients, and hyperthyroidism in 3%. There is other things a couple classifications of subacute thyroiditis, and these can be things that are transient, like it can happen for a little while and then it goes away. So this is associated with an inflammation of the thyroid gland or something like that. Postpartum. This thyroiditis can occur in 3 to 16% of women who have just had a baby. There can be a painless type, which is similar to postpartum, except there's no pregnancy. And painful, which is characterized by neck pain, low-grade fever, myalgia, which is pain, tender diffuse goiter, and swings in the thyroid function test. With those thyroid nodules that I talked about earlier that can be taken out with fine needle aspiration, it's interesting that we do find nodules in 6.4% of adult women and 1.5% of men. They're not always cancerous. Only 5 to 9% of them prove to be thyroid cancer. And again, they would do the fine needle aspiration. They would do cytology examination to check and see if there are cancer cells. In that case, there would be surgical removal. And this completes our section on thyroid hormones.